Thank you very much, Mirko, and thanks to the organization for inviting me. It's a real pleasure. So, VA ECMO weaning, these are my conflicts of interest, and I would like to touch on clinical aspects, but especially I would like to stress that the patient-specific pathophysiology is extremely important when talking about VA ECMO weaning, and I will touch obviously on the current literature. So in general, and that has been pointed out already, weaning from VA ECMO starts with reflection on the etiology and coming up with an educated guess on the severity of the disease that must, of course, allow recovery. There should be hemodynamic stability of the individual patient. The pulmonary function should not be significantly impaired. And in the end, the patient must be ready to tolerate a weaning trial. So essentially meet hemodynamic and echocardiographic weaning criteria. And I will come to that in a minute. So successful weaning from VA ECMO, and that should be considered from the very beginning, is optimal ICU and ECMO management. So individualized tailoring of ECMO support flow, and that has been addressed by previous speakers already. The toxic effect, as Federico called it, of inotropes and vasopressors. So I'm very much in favor of really reflecting why is your patient on inotropic therapy when at the same time he or she is on mechanical support. So is that reasonable? Does that not create too much calcium overload? And does that not hamper the myocardial recovery? And also, obviously, vasopressor dosage and fluid loading are very, very important. Ventilator settings, I think in the literature, this is still a gap. So there is not much known on what we should do with a ventilator, and I will come to that in a minute. And obviously, if things turn out the good way, stop sedation, mobilize your patient, ambulate him on ECMO and concomitant devices. So coming to the clinics, this is the 46-year-old male, acute myocardial infarction, dissection of the left main, so-called revascularized successfully. You see the intra-aortic balloon pump is initiated. That is a case from a couple of years ago when the balloon pump was still attractive, but in the end, there is refractory cardiogenic shock, and that is a typical patient that requires short-term mechanical support, obviously, and balloon pump is not sufficient. There is also a huge respiratory problem, and you know all these critical patients where the TE probe is still in the patient, so it's a very, very critical and urgent situation, and that is the classical indication for bifemoral cannulation of VA ECMO. And you can see here, as indicated in this picture by the arrows, obviously there is a competition between the function of the native heart and the Impella pump. That is nicely visualized here in the pressure tracing of the arterial line. You see a reduced pulse pressure on the left side, and when the heart recovers, the pulse pressure rises, and you can also see that the zone of competition between the native heart and the ECMO is moving more to a distal location, as pointed out in the lower panel and the fluoroscopic images. So I think it's very relevant when we talk about ECMO to consider basic laws of cardiac mechanical load, of wall stress. It's this Laplace law. So what counts is the pressure in the cavity, and it is the geometry that dictates wall stress and also deformation. So the wall thickness in the end is also an important factor. So you should keep this in mind. And why is that important? And that brings me back to basic physiology. And you've seen that all the other speakers also have shown the pressure volume loops, the normal situation in brown, acute heart failure in blue. And you see here theoretically that the Impella does pretty much what a mechanical support device should do with a failing left ventricle. And that supports the idea of the ECPella strategy and not so much the ECMella strategy. But VECMO as an isolated strategy actually shifts the pressure volume loop to the wrong side and upwards in terms of end-diastolic pressures, and as you can see here in the red loop, and that is probably not what you want. But this also shows you that it is very, very important to consider the very individual patient, and that is why we looked a bit more into details together with Michael Bromé from the Karolinska Institute. You have probably seen this computer simulation of human cardiovascular system before, and we have used in a couple of studies the simulation to calculate what would go on in a patient if we would do a certain intervention in terms of ECMO flow, in terms of venting. And obviously, if you think a bit about this, you can use clinical parameters as echocardiography and hemodynamics as input parameters for computer modeling. And then we are very close to specific patient individualized decision support at the bedside. So, for example, here, a severe cardiogenic shock of 35-year-old female, and what would happen if we would start ECMO? We did this in retrospect with the clinical data. We modeled the patient, and you can see here the left and the right pressure volume loop, and you can see here classically that the left ventricle is dilated, the pressure volume loop is shifting to the right, which is obviously unwanted. And we have touched also on other calculations of left ventricular unloading interventions, and I will not go into detail into that, but if you're interested, you can have a look at our data supplement, which has also been published on YouTube by the ASIO Journal. But it's probably more important to reflect a bit more on what veno-arterial ECMO does in the individual patient, and I think this is a very important abstract from a very experienced ECMO group from Melbourne, Australia, and what they found is that veno-arterial ECMO reduces left ventricular dimensions in patients with cardiogenic shock, and this has been an abstract in 2018 on the American College. And so if you think about that, you might think, why is that? Did they do something wrong, or did they measure the wrong geometry, or what is that? Is it due to the retrospective nature of the data? But it could also be that the right ventricle is very important, and the right ventricle may potentially dictate the level of LV overload. That the right ventricle is important in ECMO weaning, that has been known for some time. If you look to this study using three-dimensional echo, the right ventricular ejection fraction is very important for weaning success. The cutoff here that dictates not only the success but also the survival of ECMO is 25%, and that shows us that we should not only focus on the left ventricle but also the right ventricle. And coming back to this right ventricular, left ventricular issue under VA ECMO, we looked into the simulation again, and we looked into the question, what would happen if we would increase right heart contractility independently of the left heart? So that really changes the right and left ventricular interdependency. And you can see here that the right heart contractility really dictates the degree of left ventricular overload. And that is very logical if you think about it. And that is, in fact, independent of ECMO. The right heart simply is capable with a certain preload to just eject and overload the left ventricle with a constant contraflow of the ECMO pump. And that will lead, of course, to pulmonary edema and high wedge pressures. And pulmonary edema, that is very well known in ECMO, that is a huge problem, increased afterload and insufficient LV unloading. 30% of patients, but probably more, it's a feared and a significant limitation of VA ECMO. But there is more to pulmonary edema. Just think about the dual pulmonary blood supply. There is the pulmonary artery and there's the bronchial circulation. But if you think about it, you will see that the pulmonary artery is very, very important for the perfusion of the lung. And if you consider high flow ECMO, so maximum venous drainage, let's say, of 80% of the cardiac output, you reduce pulmonary circulation by 20%. And that might be very critical. So this reduction of pulmonary blood flow as a function of increasing ECLS support flow in experimental settings, it has been shown that that may create ischemia of the lungs if you do that for a prolonged period of the time. And 25% of the systemic cardiac output is probably a cutoff also in the clinical setting. And that will reflect itself probably only by pulmonary edema. And that is probably something which we do not address so much in our clinical work. So I think pulmonary edema is a very complex clinical real-world scenario. There's a cardiogenic reason, there's a high flow via ECMO origin of that, LV congestion, but there is also potentially pulmonary ischemia when you go for a high degree of central venous drainage. So in high flow via ECMO, if you reduce that a little, you will be facing pulmonary reperfusion edema, all kinds of atelectasis, and then you run into a very multi-mechanistic pulmonary and cardiac failure situation. And the question then remains, what is now the optimal contribution and combination of tailoring these support modalities in that very specific individual patient that you're dealing with. There is not much known about mechanical ventilation during extracorporeal membrane oxygenation. This paper from Mathieu Schmid from Paris touches on VV ECMO and not so much on VA. But in the end, probably adequate PEEP is important, just to counterbalance the high hydrostatic pressure that we generate when we overload the left ventricle. And that has implications also in the long run. If you bridge successfully, for example, to LVAD, you can see here that in the long run, after a year, the percentage of patients that survives the fat implantation is lower in the patients that develop acute lung injury. And that is, of course, also the population that has the pulmonary edema. The daily fluid balance is important. That holds for many, many ICU patients. That is not surprising that dictates survival. And obviously, if you can do awake ECMO and detubate the patient, that is the optimal setting, and you can mobilize the patient as well. And that will be achieved by reducing VA ECMO blood flow, and that should be a default, as Martin Barlick already pointed out. And obviously, you should try to reduce your hypervolemia if applicable. And then, as the Regensburg group has traditionally and classically shown, that awake peripheral via ECMO is very capable of letting the patient be awake, spontaneously breathing, and practicing. So, in some patients, as in this one, a 45-year-old female with a very abnormal ECG, you might wonder whether a weaning strategy is always possible. So you see here a very typical apical ballooning of the heart, cardiogenic shock, but normal coronaries. And you see after 3 days, there's complete recovery. And this was a stress-induced cardiomyopathy. So there is not much to reflect in this patient in terms of a weaning strategy. And after 6 weeks, you see there is almost a complete recovery. But optimal styming is generally a very, very difficult and challenging issue. So when should we start weaning? It's among the greatest challenges. You should weigh all the benefits of ECMO and the complications is bleeding, limb ischemia, the neurological severe complications, organ hypoperfusion, and infections after longer runs. And you should really identify the patient in time that is weanable and that is not weanable. So individualized weaning strategies are very important depending on the underlying disease, as I pointed out in the beginning. Probably a weaning trial within the first 2 days is, I think, something which we should reflect on as well. So it might interfere with cardiac recovery if you overstress the heart in a very critical phase. Post-cardiotomy and post-infarction stunning, I think you might want to keep in mind that after a couple of days, you should expect recovery. Myocarditis will be a much longer natural course. And I think you should always consider weaning within the first day or 2 days when there is hemodynamic and clinical stability. Biomarkers, this is, I think, an interesting study, but probably does not meet all mechanistic insights. Seems not to be predictive, but that is something which I think should be sorted out for the very well characterized individual patient. And what about echo? Well, Nadia Azoui has published a lot of papers, reviews, and all original contributions on the classical VTI, the ejection fraction, and the TDAS wave that should pass a certain threshold. And you should always keep in mind that there are a lot of left ventricular function parameters in echo, and the right ventricular function is not so well defined, although I pointed already out that that might be an important focus. And you should clearly look into what is the parameter predicting. Is it during full support, or is it really during a weaning trial that the parameters apply to? So this paper, very recent paper in the Journal of the American Society of Echocardiography, proposes some new predictors of VA weaning success, but in fact, these are tissue Doppler parameters and quite traditional parameters that are not really surprising. And if you look in more detail, if you compare the traditional parameters with the introduction of some new parameters, you see more discriminatory power. But the question comes up whether this is a bit the same story as the classical parameters. Essentially, it looks to the same parameters. I wonder whether, and I think the literature still is lacking information on that probably the continuous hemodynamic and echocardiographic monitoring is not really well known. So I show you this slide and the weaning protocol of a very small study using a continuous disposable transesophageal echo device. I will not go through it in all details, but it shows you that if we would be able to monitor the patient on a daily basis very carefully and probably continuously and look into the heart in function of the support flow and look very carefully how the parameters would change over time, I think then we would have probably much more valuable information. And that is probably future of more sophisticated weaning. So prolonged VA ECMO with persistent RV overload to conclude in this patient with thromboembolectomy for pulmonary embolism was a classical case where right ventricular failure is the issue and should be weaned. Well, we use the arteriovenous bridge for gradual weaning in the past, and then you have the opportunity that you can clamp the bridge gradually, and in that way you can obviously run a high flow through your circuit and reduce the flow to your patient. So that is a very gradual and way of weaning through the days, actually. And another interesting option is, in that context, is the pump control retrograde trial off, where in a pump controlled way, you actually turn the ECMO circuit flow direction around. This comes from pediatric ECMO, and there have been a lot of small papers studied on that. But in the end, I would like to conclude that there is not only the cardiac function that should be assessed, but there is also pulmonary function and the role of the ventilatory pressures that counts. And you see here, when you look into cardiac functions by ejection time of the left ventricle versus pulmonary artery wedge pressure, you get a more integrated physiology picture of the individual patient. And I think that is the way to go and to gain new insights. So successful weaning from VA ECMO is an individualized approach. Underlying disease is important, patient-specific significance and time course, and you should go for a very close and daily serial assessment. Optimal ICU management, clinical weaning prerequisites and endpoints should be well defined by educated guests from the very beginning. You should go for a perfect balance between the degree of extracorporeal support and the toxic inotropes, vasopressors, and fluid overloading. You should not only consider LV unloading and additional strategies, but look into the role of the right and left ventricular interdependence. So if your right ventricle is weak, you probably are not in so much in need of LV unloading. Look to your ventilator settings and your pressures. So what is the impact of that on your heart? And in the end, you should go for awake VA, detubation, and mobilization. Thank you very much.
Thank you so much, Dirk. And now I think that it's time for understand and know what about the nurse point of view in this patient. And it's a really big pleasure to introduce Kathleen Delee. She's a consultant nurse in critical care medicine and lead the ECMO nurse, adult ECMO nurse team